Impact of case difficulty, endodontic mishaps, and an instrumentation method on endodontic treatment outcome and quality of life, a 4-year follow-up study by Dr. Johansen in 2022 in Norway. We recently reported that case difficulty had an impact on the occurrence of endodontic mishaps in an undergraduate student clinic. Teeth that were categorized as high difficult according to the American Association of Endodontists case difficulty assessment form were shown to need significantly more dental treatment visits to complete the root canal treatment and resulted in a significantly more endodontic mishaps, such as instrument separation, canal transportation, loss of working length, short obturation, and overfill with gutta percha. According to the World Health Organization, quality of life refers to as an individual precipitations to their positions in life within the context of the culture and value systems as well as their goals, expectations, and beliefs, which used to consist of 49 items to be assessed, and to simplify it now, it only contained 14 items. The World Health Organization International Classification of Impairments, Disabilities, and Handicaps testing the following 7 dimensions of impact: functional limitations, pain, psychological discomfort, physical disability, psychological disability, social disabilities, and handicaps. The aim of the study was to investigate the treatment outcome 4 years after primary non-surgical root canal treatment was performed in an undergraduate student clinic with a case difficulty, an instrumentation method, endodontic mishaps, and coronal restorations as variable. They brought 234 patients which received a primary non-surgical root canal treatment over a 257 teeth over a period of 4 to 6 years. The treatment was performed by 2 consecutive classes of a 4-year dental students using the hand files and reciprocating wavelength file for an instrumentation. The teeth that were missing, extracted, retreated surgically or non-surgically, were recorded as an early failure and excluded from further statistical analysis. The clinical examination, the patient's chief complaint regarding treated tooth were registered, and the pain sensation was taken by a numeric rating scores from 0 to 10. All the clinical examination was performed by one examiner. For the radiographical examination, they took a periapical radiograph and additional radiograph if it were necessary, and one observer interpreted all the radiographs. For the outcome, the clinical success was defined as an absence of clinical signs and symptoms like the pain and percussion and palpation tenderness, sinus tract, and endodontical pocket to the apex, with the presence of at least one was evaluated as a clinical failure, whereas the PIA scores 3, 4, and 5 were registered as a radiographical failure. For the results, the data of the 257 root-filled teeth were analyzed. 19 was registered as an early failure and was excluded from the study. 78 teeth were not included in the study because the subjects declined to participate or could not be contacted or they were diseased. For the radiographical assessment, 95.6 had a lower or unchanged BIA score at the recall visit. For the clinical finding, they result in a clinical success of 88.8%. Surprisingly, none of the endodontical mishaps in this study caused any clinical signs and symptoms. However, the numbers of this study were too low to make a conclusion. So to conclude this paper, teeth in a high difficulty category, like the molars and teeth treated with an engine-driven file, presented with a significantly more clinical signs and symptoms and not periapical lesions 4 years after the treatment completion. The presence of clinical signs and symptoms rather than the PIA score affected the patient oral health-related quality of life.